Hi, good morning, everyone. Welcome to our 133rd session on CMAAO platform. We are live on various social media, and today we are covering a very important topic. We have seen a lot of organizations. Just let me mute people. Okay, we have seen a lot of organizations, including WHO, who has been working on this particular issue, and I think there is a background noise coming up. So today we are talking about Unite, the end of tuberculosis. We are on 133rd CMAAO International Weekly Meeting. Today we have a very important speaker, Dr. Surya Kant, professor and head from Department of Respiratory Medicine. He is King George Medical University, UP Lucknow. He's a national vice chairman for IMA AMS. He's a brand ambassador of COVID vaccination, National Health Mission. He's a chairman for North Zone 9 States Task Force NTEB. He's a convener for Tobacco Pollution TB Free Campaign. So we welcome you on this platform, and we would like you to enlighten us with the knowledge what the world is going to do about TB. And we have among with us all the 19 associations. I welcome Dr. Chong from our chair and Dr. Wazi Kazi, who is from Pakistan as a president of CMAAO, and we have people from US as well. Dr. Monica Vasudev. Thank you so much. Over to you.
Thank you, Saurabh. Namaste and greetings from India. So welcome to the all associations of CMAAO and representatives of these countries. And today you have, of course, kept very important topic, that is Unite to end TB. This is the very high time when we have to unite hand together for fighting against tuberculosis. You see, we in 2.5 years, we have seen the COVID pandemic. And in January 22, COVID was declared as a global health emergency. But we have to remember that tuberculosis was declared as a global health emergency in year 1993 by WHO. So almost, I can say 29 years back, that tuberculosis was declared as a global health emergency. Dear friends and colleagues, the very important landmark in the history of tuberculosis is 24th March 1882, when the Robert Koch, a German scientist, German pathologist, discovered the causative organism of tuberculosis 140 years back. So we were knowing 140 years back the causative organism of the disease tuberculosis. And that's why the Nobel Prize was also conferred on him in 1905. So after 140 years of discovery of the causative organism, we know our enemy, we know the causative organism of TB is still the global health emergency is continued for last 29 years. I don't know that any disease has been witnessed the long WHO declared global health emergency in the history of WHO. Only disease is tuberculosis. Now, the second important landmark in the history of tuberculosis is 1944, when the first anti-tubercular drug came into existence, that is streptomycin. So that is also a long journey. Around 78 years back, we discovered the first anti-tubercular drug. Until then, we have had a lot of anti-tubercular drugs. Latestly, we have 2 anti-tubercular drugs, that is bedaquiline and delamanid, also in our tools in the armamentarium of the treating tuberculosis. But still, we are fighting tuberculosis. 10 million new cases of tuberculosis occurring throughout the world yearly, per year. 10 million, yes, my dear friend, 10 million. And if you see the Indian scenario, every 4th patient of tuberculosis in the globe is from India. Every 3rd patient dying due to tuberculosis is from India. And 31% of the global MDR TB share is also from India. So I think India is the highest burden TB country. And that's why we have privilege to address this disease. And that's why our Honorable Prime Minister on 13th March 2018 in presence of Director General WHO at Delhi, our national capital of India, declared a very ambitious goal of ending tuberculosis from this country by 2025, which is 5 years ahead a globe of the SDG target. Sustainable Development Goal has declared an TB target by 2030. But our Honorable Prime Minister Sri Narendra Modi ji has declared this target 5 years ahead of this. And that is too in presence of Director General WHO. Fortunately, I was also present in that meeting in Delhi on that day, that is the 13th March 2000. So the third landmark, important landmark in the history of tuberculosis is 13th March 2018, when Prime Minister declared this ambitious target. Also, we suffered a lot in last 2.5 years due to COVID, and that's why notification of TB cases and diagnostic and treatment facility modalities and even health power engaged with this management process were diverted towards the COVID-19. So TB affected worse during 2.5 years. Anyway, India has successfully controlled tuberculosis and controlled COVID also. And now we are in the gearing up process of, we have not controlled tuberculosis, we have controlled COVID, and now we are gearing up for the controlling tuberculosis, for eliminating tuberculosis. Now, before the, of course, per se about the tuberculosis, I would share my viewpoints. What are the riders against the TB elimination? And that we have to address. There may be a little bit geographical variation in this region, Southeast Asia or the CMAAO countries, but majority of country representative will agree to me that these riders are the common riders for all the countries of CMAAO. Rider number one, that is majorly hurdling the elimination of TB program, is the malnutrition. My dear friends, malnutrition is a very important vulnerable factor for development of active disease of tuberculosis. Now, tuberculosis infection is a different thing and tuberculosis disease is a different thing. Tuberculosis infection means that you have been exposed to a TB patient. All TB patients, they are not spreading the disease, we should remember. Only those TB patients who are excreting the Mycobacterium tuberculosis, TB bacilli, they are the patient who will cough or sneeze or laugh. They will spread the TB bacilli in the form of droplet nuclei. One bout of cough from a TB patient releases 3,500 bacilli, and even single bacillus enough to cause the disease. So this is called exposure of the TB. Extrapulmonary tuberculosis patient, sputum negative pulmonary tuberculosis patient cannot spread to the others. So we should not advocate that TB is a dangerous disease and we should not fear it. Because tubercular meningitis, brain TB, abdominal TB, lymph node TB, bone and joint TB, these TB patients are not able to disseminate the disease, not able to spread the disease. They are non-infectious. So we should not discriminate socially. TB patient need affection, love, emotion, and care, not social discrimination. I think we have to address this issue also across the boundary of the globe, across the boundaries of the countries, because this is a common issue. Especially in India, we are facing a lot of discrimination with the TB patient. Husbands are giving their divorce to the wives when they develop TB. Children suffering TB, they are being socially boycotted in the school, that this fellow is having TB and my son will not play with him. So such kind of things will not happen. We have to address TB is not only an active disease. TB is not only disease, although TB is a disease which will not only affect the lung, it can affect from brain to toe, any part of the body, except hair and nail. These are the two organs of the body which are not affected by TB, but otherwise every organ can be affected by TB. But we should not discriminate socially. This is the first and foremost, I think, my folded hand request that in each country of CMAAO, dear representatives of these countries present in the meeting, please fight against this social discrimination of the TB cases. This is a very important issue. TB patient will not die due to tuberculosis, but will have a lot of psychological problems, stress, depression, frustration, suicidal tendency because of this social discrimination. So we have to fight together, first and foremostly, the nutrition, the malnutrition, and social discrimination. These are the two important issues. I don't know what the scenario in other countries the people will share during the discussion, but my folded hand request is that first and foremost, we have to fight against two important factors: social discrimination against TB cases, TB patient, and second is the nutrition, the problem of malnutrition. So that's why in our country, our Prime Minister, when he launched the NTB program or NTB by 2024 program, he also launched a program called Nutritional Support for TB Patients. I don't know how many countries are running this nutritional support program for, but now India is running for last 4 years, and crores of rupees. This has been as a direct benefit transfer to the account of the TB patient. So there should be no corruption in that distribution of the money. As a part of as given as a nutritional support for the TB patient, just to encourage and enhance the nutrition of the TB patient. And our governor of Uttar Pradesh, to which I belong, the King George Medical University, Lucknow, heading the Department of Respiratory Medicine, as introduced by Dr. Saurabh Agarwal. My governor, Srimati Anandiben Patel, she launched a special campaign when she joined the governor of Uttar Pradesh in 2019, 3 years back, that universities, doctors, NGOs, everybody should come forward for the nutritional support and emotional support for the TB patient. And she TB adoption program. Means the society and NGOs, doctors, university professors, the media houses, the corporate houses, they should adopt the TB patient. And once a month, they should meet to the TB patient, give some nutritional support, give some emotional support, address the issue of the social issues, social discrimination. So purpose of this nutritional support program by our governor is to provide the emotional and nutritional support. They are discriminated, they are being neglected by the society or even in their houses, in their homes. So this program initiated by our governor, our Department of Respiratory Medicine, myself has also adopted more than 100 TB children suffering. A national program. And you see in our India, it is not only Prime Minister concerned now, but President of India, Srimati Draupadi Murmu, recently India, she has launched a special program called Pradhan Mantri TB Mukt Bharat Abhiyan on 9th September 2022. So President of India, Prime Minister of India, Governor of my state, every important stakeholder are involved in the TB elimination program. And Prime Minister has already requested, rather has made a call for involvement of everyone, whosoever. It has to become a mass movement for addressing the issue of TB elimination program. So our request is, on priority basis, we have to address two issues. One is social discrimination, second is the nutrition. Now coming to the third rider for the elimination of TB program, that is smoking and other addictions. You see, India has got 120 million people who are smokers. And smoking, our department has done a study that smokers have 2.5 times higher chances for developing pulmonary tuberculosis or any tuberculosis. So my dear friends, we have to, of course, launch a special campaign for smoking cessation and ask people, dear friends, you are not only at the smoking health hazard, you are also at the health hazard of TB, and so please stop smoking. Another rider is the air pollution, very important. And we have seen that air pollution is now a global problem. And India's most of these, some important cities, the larger cities, they are having a lot of air pollution problem, including the national capital, Delhi. So air pollution has got also important vulnerability for the development of tuberculosis. And of course, then the population and overcrowding. Another factor for India. India is having 1/6 population of the globe, but the geographic area is less. And that's why there is a overcrowding. So those countries who are having overpopulation and overcrowding problem, the communication or spread of the disease is also more in these countries, in the society, in that geographical area. And that's why we have to address the issue of air pollution also if we really want to check the TB in this country or in the globe. Another problem is the immunocompromised disease. Yes, diseases like diabetes, HIV, cancer, other immunocompromised disease, they are having 4 to 8 times more chances for developing tuberculosis. And that's why we have to address in our own country the all problem. If diabetes is not control of diabetics, so of course he is more vulnerable for developing tuberculosis, and that is to severe form of tuberculosis. So India has got around 700 million cases of diabetes. And of course, diabetes is a global problem and major problem of the health. And this is a very risk factor for tuberculosis also. And if you want to really the dual link of diabetes and tuberculosis, you can read my article, Diabetes and Tuberculosis are Double Trouble, in the Journal of Indian Medical Association, published in a few years back. Now, another problem is the problem related with females. Why I'm addressing this? Because most of the developing countries had a system that early marriage and more children. Now, females who are having early marriage, early pregnancy, and having repeated pregnancy at a shorter intervals, they are more vulnerable for developing tuberculosis. So we have to address to our female adolescent child that please not marry early and not having too much of pregnancy, not much having early pregnancy, because their body is not capable to cope up with the pregnancy and they are developing pregnancy, and that's why become immunocompromised. So we have to address this issue also for the females, that early pregnancy and repeated pregnancy at a shorter interval is a very important risk factor for developing tuberculosis in females. So I think we have to address specifically for the females the issue of early marriage and repeated pregnancy at a shorter intervals, which are having more chances for developing tuberculosis or extrapulmonary tuberculosis. So I think these are the certain, and stress. Stress is also very important risk factor for converging latent TB into the active TB. Dear friends, when somebody get exposed, there are chances of 30% that he will develop TB infection. And after the infection, there are only 10% lifetime risk for developing active disease. So only exposure to the Mycobacterium tuberculosis or TB patient is not necessarily that he will have tuberculosis from next day onwards. It is the basically interaction of the tubercular bacilli and your immunity. If your immunity is strong, lifelong, you have exposure and infection of TB. And that's why it is requested that the infection is important for TB, but nutrition is equally important. If your patient, if your society is nutritionally competent, they will not develop tuberculosis even after exposure and infection with TB. I think these are my viewpoints, that TB has to become a social movement, a public movement. Everybody has to be involved, from president to prime minister, to the doctors, to the society, to the media, to the charitable organization, to the corporate houses, and even a common man, number one. And number two, we have to address certain issues, for example, social discrimination, for example, nutrition problem, for example, population and overcrowding, air pollution, smoking and other addictions. And especially in females, I said that early pregnancy and repeated pregnancy at a shorter intervals. And in the competitive, of course, time, the stress is also very important rider, I would say. And then, of course, you have to develop very good health infrastructure. You have to do the advocacy that whosoever one is having cough for more than 2 weeks should be investigated for tuberculosis. And every child who is not growing should be addressed for the diagnosis of tuberculosis. So children who are malnourished, who are having the growth retardation, they should be addressed. They are the cases of presumptive TB, and they should be investigated for. Of course, everybody should become, even the small healthcare infrastructure, everybody should be aware what are the TB, presumptive TB. So presumptive TB can be anybody who is having cough for more than 2 weeks, decreased appetite, weight loss, blood in sputum, or fever for more than 2 weeks. So all such cases should be, in India, we have started active TB case finding. What does it mean? That TB, a mobile van equipped with the TB diagnostic facility goes to the slum area, goes to the rural area, goes to the tribal area. For those areas who are more vulnerable for developing tuberculosis, but having less facility of health infrastructure. So TB mobile diagnostic van launched in 2019 by then Health Minister of India. These mobile vans are going for active case finding. So we need a social movement, a public movement, and we should fight against the social discrimination against TB cases. So that is all from my side. And again, greetings from India, greetings from my institution, King George Medical University, Lucknow. Lucknow is the capital of Uttar Pradesh, the largest state of India. Thank you very much. Yes, Saurabh, up to you.
It was a very nice and very crisp discussion about TB. I would like to invite everyone else for the comments and questions. Over to you, Dr. Chong.
Dr. Kant, thank you very much for the Dr. Surya Kant, thank you very much for the very wonderful talk on TB. It's still an old enemy in Singapore. We still have about 2,000 to 3,000 new cases a year. In half of them are in our Singapore citizens and permanent residents. The other half are in the workers who come in from abroad. Construction workers, whatever, helpers, and so on. So it's still a big problem in Singapore. And we still have, we recently had a block of flats. There are these government flats in Singapore. About 90% of our population live in government flats. And there was an entire block of flats that had TB in Singapore. So it's still around. The old enemy is still around. And also, I'm just curious to ask, what can you tell us a little bit more about MDRT? Because we're also a bit concerned with that.
Yes. So I mentioned that drug-resistant TB is a problem in India and a global problem also. And 31% of MDR TB cases, they are from India. So what is the MDR TB? Basically, we can divide TB into two types, sensitive TB and drug-resistant. Sensitive TB means the mycobacterium tuberculosis or the sample from the pulmonary tuberculosis case is sensitive to the first-line anti-tubercular drugs, that is rifampicin, ethambutol, and paracetamide. For drug-resistant TB, any of the drugs they are patient-resistant to it. The particularly patient is having resistance to two important anti-tubercular drugs, or in addition to it, that is rifampicin and isoniazid. Rifampicin and isoniazid are the two important anti-tubercular drugs, and if the patient is resistant to these drugs, with or without resistance to other drugs, then we declare a patient as multi-drug resistant TB. The treatment of sensitive TB is very simple: 4 drugs for 2 months and 4 drugs for the rest of the 4 months. 3 drugs for the rest of the 4 months. So total 6 months within 6 months. But the treatment for multi-drug resistant TB is a very demanding and complicated treatment. We need fewer drugs like Dalaperid and Bedaquiline, and we need some drugs which are having more side effects. So treatment of multi-drug TB is a longer treatment, 1 year to 3 years. Treatment of MDR TB needs special care because everybody cannot prescribe, every doctor cannot prescribe the treatment of multi-drug resistant TB. Drug TB center. So in every district of India, we have a center for management of drug resistant TB. And of course, the center has to manage all these MDR TB cases in that particular district. And then we have super drug resistant TB center, especially meant for MDR TB. They are called nodal drug resistant TB center. So in India, each medical college has the facility of the management of drug resistant TB center. And our National Medical Council has given a mandate, a gazette notification for every new medical college to develop the facility of treatment of drug resistant TB, MDR TB, within 4th year of its inception. So any medical college after 3 years has to develop the facility for the treatment of MDR TB. So I think we have good infrastructure and facility support from the government and we have to involve the private practitioner also, because only public sector cannot address the issue of MDR TB. We have to involve private sector also. So we have private sector involvement also for the drug resistance TB. The only problem with multi-drug resistance TB is that if multi-drug resistant TB coughing and is spreading the disease, he will spread the multi-drug resistant TB to other fellows, not sensitive TB. So we have to check the prevention and transmission of MDR TB to the society. That's a really, of course, very important challenge for us to diagnose MDR TB and then, of course, prevent MDR TB transmission. And that's why during COVID times, we have the very important tradition of wearing the mask and keeping the distance, physical distance to the people. I think these two things which we have learned during COVID times, although mask is not too much effective as it can spread the COVID-19, but usually it is 70-80% it is effective. Although it is effective at 98% in cases of COVID-19 transmission. So mask and the maintenance of physical distance to those who are coughing or having fever, I think this two important, they can very well prevent the transmission of multi-drug resistance TB. And when another entity is called extensive drug resistance TB, means when the person is not only resistant to the rifampicin INH, but also important having drug resistance against important drugs like quinolones, amoxifloxacin or levofloxacin or other advanced drugs. So that is more dangerous situation than the multi-drug resistance TB. So India has got 31% global share of MDR TB cases, and we have to address this issue also. The important question for the society is, when the MDR TB patient will cough, it will not spread the sensitive TB, but it will spread the multi-drug resistance TB, MDR TB to the others. So I think we have to identify, and that's why 100% mandatory notification of TB cases is practiced in India and has become that by a gazette notification, it has been made mandatory, compulsory for each and every doctor of India, each and every health facility for the India, that please diagnose TB and notify the TB so that we can identify whether person is suffering from sensitive TB or MDR TB. Yes, up to you.
Thank you so much, Dr. Kant, for that beautiful response. I'd like to call on Dr. Hussain for his questions.
Yeah, thank you, Monica. Thank you, Dr. Susan. Excellent information and some of the new thing I have learned today. My first question is, at point of care of TB testing, are you using traditional testing or PCR at point of care? Second one is, what is the TB and HIV ratio in India at the moment? And you mentioned 31% of MDR. So if how's the cost of managing one patient in MDR TB? The last question is very something new, early marriage and repeated pregnancy and can have a TB. So like to know, is it not if we delay motherhood, the women's rights and their choice, how do you balance that? Thank you.
Okay, wonderful 5 questions. If I remember correctly, so I have to answer the first question. And that is what, so I'm coming to that question which I remember correctly. Okay, so first coming to the TB and HIV. You see, HIV patients in India, they are declining in last 1 decade. So we are having less number of now TB HIV cases, and we are addressing both programs. It is mandatory in India now that every patient of TB should be screened for HIV and every patient of HIV should be screened for TB. So dual order is there. So every health facility, every doctor in India is screening all HIV patients for TB and all TB patients for HIV. It's a mandatory now. So we are having close watch on the HIV TB interaction, and HIV patients have 50 times more risk for developing tuberculosis. So I think this issue is a very important issue for us, and we are having HIV declining trend, and that's why we are having less number of HIV TB also. Roughly 1 to 2% TB patient, they are HIV positive, and similar kind of patients of HIV developing now tuberculosis. And we have reduced mortality also by addressing the anti-HIV treatment, antiretroviral treatment to the HIV patient same time, and if a patient having HIV and TB both diseases, so we start anti-tubercular TB treatment first, and later on we can meantime investigate and of course plan for the treatment of HIV. So this is our policy for HIV and TB. Second, you mentioned about the cost of the treatment. So in India, the treatment support for the TB patient is entirely free. Not a single penny is being charged either for diagnosis or for treatment of tuberculosis, whether it may be sensitive TB or it may be MDR TB or XDR TB. For example, in MDR TB and XDR TB, the cost of treatment you asked, the cost of treatment is in lakhs and lakhs rupees. So I would say more than $2,000 can cost for the treatment of MDR TB or XDR TB in India, but this is totally free for irrespective of the all status of the TB patient. So TB may be a disease of poor, TB may be a disease of even rich patient, but everybody is getting free TB patient. A newer drug called bedaquiline, single drug for 6 months costing 2 lakhs rupees in Indian currency. So that is also being freely distributed. So there is no cost, and even add on to this, free diagnosis for all TB patient, free treatment for all TB patient. In addition to it, 500 Indian currency rupees per month for the nutritional support to the TB patient. The third, another question which you asked, very important question, that the human right of the females. You see, human right of females is that early marriage, we have to prevent. The females are raising the voice that women should not get married early. Why? Because in India, there are a lot of states where even at the age of 15, 16, 17 years, the females are being married. This age is not for getting, the body is not, body organs, especially the female genital organs are not matured, not developed fully to conceive the fetus, to conceive the child. And that's why as a health issue, all females, if they conceive early, they have early pregnancy, they are not only facing for the extra risk of tuberculosis, they're also facing the risk of intrauterine death of the child, intrauterine growth retardation of the child, even the risk of postpartum hemorrhage and bleeding from the female genital organs and death. So there is a lot of health issue if the female is having early marriage and early pregnancy. So the females are raising the issue in India. I think everywhere this is also true, that the age of the marriage should not be less than 18 years. And the government of India has raised the age of marriage in our country is 21 years. Even in some states now, the females, young females are being married, and we have to oppose it. The law is there. So law of land is that females should not marry before 21. If they're marrying at 21, so they can conceive at age of 22, 23, 24. This is fine, absolutely fine. And then, of course, we have a not law, but a request from the government that there should be a 5 years interval between the two pregnancy. And like China, we have not banned more than 1 or 2 child, but we have requested the public democratically. We are a democratic country, so we have requested democratically that please don't have more than 2 children. So our government policy is that age of the female should be when female is 21 or more in age, and the gap between 2 pregnancies should be more than 5 years. And third, we should not have more than children. This is our government policy. And you stated about the human right of the females. Yes, it is the human right of females to have the child, but it is not the human right that you are targeting the female health by early age. So I think no human right, no international policy, or no women will say that please allow the early pregnancy and the early marriage. So rather now trend from last 1 decade in India is that now people, they are not, the now female, they're not getting early marriage and early pregnancy and not too much pregnancy. So I think I have addressed this question. And I just forget your another question, last question. What was that, sir?
The point of care of tuberculosis, are you using PCR or other method?
Fantastic. So we are not using the traditional one now. We are using, yes, PCR-based tests, The first point of test is the nucleic acid amplification test, which is PCR based, and sputum is subjected for this test. And good news is that till a few years back, till 2018, we are using a costly machine from the US, that is CVNet machine. Now India has developed its own machine that is called TrueNet machine. So in spite of CVNet, now we are having more than two machines in a hospital for diagnosing PCR-based modern tests for tuberculosis. So we are not using the traditional one. We are not using modern tests based on PCR, and that is the point of test of care. And this has been recommended by our National TB Health Program that yes, every TB suspect should be given the opportunity of doing the nucleic acid amplification test, that is PCR-based test. And that too, we are now doing with our India's machine, that is TrueNet machine. Anybody is interested in TrueNet machine, you can send a request in India. And of course, you can have the facility of this, that is cheaper also. And even this test can be done, but it is battery operated. So even electricity is not suppose available in a village or rural setting. So this can be battery operated. And a very, you see 10+2 standard passed boy, this can perform the test and result is available within 2 hours. Fantastic test. We have the point of test care for diagnosing tuberculosis.
No, thank you so much, doctor. Thank you very much.
Thank you, sir.
Dr. Pillai?
So it has been very crisp and very informative, the talk by Dr. And I also want to supplement that TB is one of the oldest diseases because even in Egyptian mummies, hair spine has been detected. So it is so old a disease which is being documented. And India has been really addressing this issue because we had different programs to suit the different situations. We had the RNPCP program, DOT, and now we have the NTB program. So from treating them in a sanatorium, we are now shifting to treating them domiciliary, particularly by the health workers going there and giving the medicine. Even the duration of treatment, definitely with the DOT and all has been reduced. MDR TB, as rightly said, is also being addressed. Private-public partnership definitely is there in TB control. Indian Medical Association, along with the government, definitely together is addressing the problem. We have a very strong established network for TB treatment because even at the district level, we have a medical officer in charge of tuberculosis and free treatment, again, as rightly pointed out, irrespective of your socioeconomic condition, everybody gets free treatment. So that is there. Two other things which I would sort of highlight. One is, of course, nutrition and pollution, smoking, and all you have highlighted well, and overcrowding, particularly in big cities where there is a lot of labor forces. Even in one unventilated room, maybe 10 or 20 people sleep. And this itself is a reason for spread of the disease, compounded by malnutrition and HIV again. Also, is another reason why dormant TB becomes fired up. Another point which I would like to bring to your notice is the missing TB cases. Almost 10 lakhs of TB cases, as per our calculation, are not being brought to our notice. And TB now is a notifiable disease. In spite of that, again, these missing cases are there. And even that has to be addressed if we are to control or if we are to fulfill the slogan of NTB. Thank you. Your comments, please.
Kant, have you got any reply on to Dr. Pillai's comments?
If I may, I just want to say thank you for a fantastic fantastic discussion. In the time that you were presenting, you summarized very key concepts. One was education and reminder that this is definitely a very old infectious disease. And it's interesting to have it in the context of a pandemic and understanding concepts of social isolation, the social stigma associated with infection for something that is respiratory driven. And then looking at cofactors such as pollution, tobacco use, immunocompromised state, early pregnancy, recurrent pregnancy, and whether or not extrapulmonary TB is infectious or not, but really focusing on the social and the public aspects of this disease. I think that what also is really focused on is making access to diagnostic tools and treatment very important, that we should continue to keep this on top of our lists, that we should not miss the diagnosis, whether or not TB is endemic and where we are living and practicing, that the presentation has to be definitely thought about in terms of weight loss and chronic cough. And cough now is definitely a symptom that we all pay attention to, no matter where the person is. And then to be able to talk about a WHO endorsed, India developed diagnostic tests. And we see that even with COVID, right? It's a PCR versus antigen test, and making sure that testing is available and bringing the test to the population as opposed to expecting the population to come to the test. I appreciate all your comments. I appreciate everything that you shared with us today. Thank you.
Dear Chong, may I say something?
Yes, please, Prof.
Thank you. Thank you very much, Surya Kant, for excellent presentation, for sparing time to CMAAO. And just I would like to say about Pakistan. Pakistan almost have the same what the Indian forces are doing over there. The Indian government is doing over there. The Indian Medical Association is doing over there. I appreciate all the efforts certainly by the government. I believe in Pakistan we have the same, that treatment of the tuberculosis is totally free. And we have the TB Association apart, and this has been about or more than a year that we have the private sector or like NGO, the concern of the TB. I appreciate what you have shown. I would like to share one thing, that to my beliefs, I understand it is a disease, but it is a social disease, I believe, more or less. That is the socio-economic, what you have said also, and Monica have also speak about it. So I think that is the problem and the issue in countries like us, like India, Bangladesh, or anywhere in the African countries, that is the socio-economic issue is the major issue. One thing I would like to share about the extrapulmonary. I'm orthopedic surgeon, and you know that the spine is one of the place where you get the tuberculosis. But at the same time, I operated a case in Pakistan, if not the globally, I'm sure about the subcontinent. It was the first case when I replaced the total knee replacement in way back 1993. Diagnosis, treatment, and going for the rehabilitation as a total knee replacement. And the results are very wonderful. And hence we see about the disability in the hip and the knee. So now the science has progressed a lot, and not talking about the countries like States or Singapore or Britain, like the countries like India and Pakistan, we also do something, and that was the first case what has been operated as tuberculosis of the knee joint, and replacement was done, and it was my humble submission to the health sciences, and was the contribution. Thank you, Chong. Thank you again, Khan. Thank you.
Any questions from the floor?
Dr. Chong, can I, Dr. Sajjad here?
Yes, Dr. Sajjad. Yes.
Okay, thank you very much. Again, it's a very good and excellent presentation by Kant. My question is that I'm Dr. Kant, I'm an ENT specialist, ENT surgeon. In Pakistan, I think it was more than 8 to 10 years that we have been receiving a lot of cases of neck nodes tuberculosis. But fortunately, we don't have the much cases, maybe few cases we find the TB lymph nodes in neck. Do you have any experience, or you can say what number of tuberculosis in neck or in larynx? Do you have any number in India? Thank you very much.
Wonderful question, sir. Sir, if you see tuberculosis, it may be pulmonary tuberculosis, means TB of lungs. It may be extrapulmonary tuberculosis, means TB of other organ. As I mentioned, except hair and of course the nails, every organ can develop tuberculosis. So in India, 80% cases are cases of TB of lung, that is pulmonary tuberculosis, and 20% cases of extrapulmonary tuberculosis. In the group of extrapulmonary tuberculosis, lymph node TB is the most common TB as a part of extrapulmonary tuberculosis. So in childhood tuberculosis, if you see the cervical lymph nodes swelling in the neck are the most common TB in the children in India. And I'm not sure, but I may assume that it is also same kind of scenario we'll find in Pakistan, also in Bangladesh, means in our Indian subcontinent. So I think the lymph node tuberculosis is a very important aspect, and that's why we used to teach the public domain that all females, whenever they are doing the bath, taking bath of their children, they should palpate here at the neck area. And every child who is having growth retardation, not getting the weight, should be presumed as presumptive TB, because TB is more prevalent in children in our country. So I think lymph node tuberculosis, which you have raised the question, is a very pertinent question, very important question. And we should always watch, and every pediatrician, every child specialist should be instructed, rather should be aware that child coming to by any symptom or any disease, he must inspect the cervical lymph node for every child, irrespective of his problem, irrespective of his complaint. Because lymph node tuberculosis, and that is through cervical lymph nodes in the necks, are the most common form of TB as far as the extrapulmonary tuberculosis is concerned. And this aspiration from the needle aspiration, that is called fine needle aspiration cytology, or sometimes we require biopsy of the lymph node should be done for the diagnosis of lymph node TB. And it should also be subjected for PCR-based test, as asked by a question from Dr. Ashraf from Pakistan, that yes, the modern test that is PCR-based CBNet, or India, we have developed our own indigenous test that is called TrueNet test. So it should be subjected, the needle aspiration, or if patient has abscess, suppose the abscess here, that is called cold abscess. TB abscess is called cold abscess because it is not hot as the usual abscess are. So that's why this aspiration of pus should be, and it should also be subjected for the PCR-based test, that is a CBNet or TrueNet. And we should also know whether this lymph node TB is sensitive TB or drug-resistant TB. So by doing this CBNet or TrueNet test, yes, with this PCR-based test, we are able to know whether TB is there or not, number one, and whether this is rifampicin sensitive or rifampicin resistant. And depending upon that scenario, we should treat patient accordingly. If it is rifampicin sensitive, then we have to give the rifampicin sensitive TB treatment. If it is resistant, then of course we have to give the drug resistant TB treatment.
Dr. Khan,
thank you very much.
Yeah, Dr. Khan, can I ask? Do you see TB meningitis in children?
Yes. TB meningitis is a very, thank you for the wonderful question. TB meningitis is a complicated form of tuberculosis of the brain. Now, TB meningitis comes under the severe form or disseminated form of TB, and it should be addressed in a separate way. Usually, we don't recommend that you extend the treatment, but for TB meningitis, a specialist opinion from neurophysician should be taken, and if need be, then we have to extend the TB treatment. Even sensitive TB or drug-resistant TB, whatever it is, we should do the CSF examination from the back, and depending upon the CSF examination report, we are diagnosing TB, and of course, this CSF, cerebrospinal fluid, should also be suspected for the treat accordingly. Extension of this is a special situation where we can extend the treatment program, extend the treatment duration, depending upon the expert opinion.
I understand BCG injection was the vaccine was supposed to address TB meningitis in children. Do you still have a lot of TB meningitis in children despite BCG?
Yes. You see, what is the role of BCG? I would say that the BCG was discovered 100 years back in 1921. Until after 100 years, we have not developed a new effective vaccine although we are in process of developing more than 100 vaccines in the pipeline. But BCG is still part of our national immunization program. What is the advantage of BCG? You see different clinical trial meta-analysis done, and this shows 0 to 80% efficacy of BCG. But anyway, why it is included in our program, that BCG cannot prevent the development of tuberculosis, but it will definitely help to have the less severe form of TB and less mortality of TB. So those are the two advantages of the BCG vaccination. And it has been researched, it has been noticed that children who are not vaccinated BCG, they are having more chances for developing tubercular meningitis in comparison to those children who have been vaccinated.
Thank you. What a great vaccine, BCG, being used for other things as well. So yeah, and I'm just curious about the TrueNet test, because I was just reading the attachment from Dr. Monica. How much does a TrueNet test cost? I'm just curious to the public.
Yes, TrueNet is equally effective than CBNet, number one. Number two is cheaper test, indigenous test developed. And number three, it can be battery operated also. It does not require a lab, a skill training. Even 2 hours training to a 10+2 standard boy, we can train how to do it. And the results are available within 2 hours. So it's a very, I think, the cost effective and the equally effective test.
And the cost to the public, does the public have to pay for this TrueNet test? And how much is it?
No. This is free. This is totally free from the government side.
Excellent. Super. I mean, nothing like local technology that's tested and proven. Yeah. Thank you. And in Singapore, I want to tell you that whenever we see a person with a big lymph node, two things. As Alvin would know from Hong Kong, nose cancer or tuberculosis.
Yeah, definitely. These are the two important differential diagnoses. Yes, either TB or cancer. Yes.
Yeah, it's TB or nose cancer in Singapore. Alvin, any comments?
Oh, thank you. Thank you very much. The talk is so informative. And thank you for your comments, everybody. And I just noticed that Professor Nizami had a very nice costume today. Is it also cold in Pakistan as well? I thought Pakistan would never get cold, but then it seems that it's quite cold there. Well, as you know, I'm a pediatrician. So in fact, my experience in Hong Kong is very limited in tuberculosis. I think for people working in chest clinic and in public health, they would have much more experiences. We still, I remember in the news, we still have about 5,000 at least cases a year. But I think most are in the adults. I didn't come across anyone for the recent 3 decades, any case in pediatric population. I don't know the situation in other places or in Singapore, but I think it is still endemic in Hong Kong. And then the most troublesome headache is the multi-resistant strain of the tuberculosis in Hong Kong. I heard that this is a big problem somehow. And then in pediatrics, I think if there were cases in tuberculosis, often we were worried about meningitis or abdominal thing. Of course, the chest TB, very, very rarely heard of in Hong Kong in pediatrics. But anyway, thank you very much for the very nice lecture today. It opened up my eyes a lot. Thank you.
Thank you, sir.
And very interestingly, I just diagnosed a 45-year-old Jewish New Yorker banker with tuberculosis 2 months ago. So, it's there, and even it affects my Caucasians who are living in Singapore, expats and so on. I diagnosed him. He had a bit of weird chest pain. I did a chest X-ray, and I found a pleural effusion. And then we followed up from there. It was eventually TB, and we treated him with 6 months of the appropriate drugs. Yeah. So yeah, quite. We do see it once in a while, once in a blue moon. I used to see some children sometimes, and for Alvin, my last case of atypical tuberculosis, which is Kanzazai, Mycobacteria kanzazai, was in a child, many years ago. He had a co-abscess, submental here, and it turned out to be Mycobacterium kanzazai, but that was a long time ago, maybe 10 years ago. Yeah. So we always think about good old TB or atypical mycobacteria whenever we see any sort of notes here that are a bit strange or weird. Yeah. Or cancer. Yeah.
Somebody asked the question in chat box. Somebody asked the question of chat box. That is how to increase the yield of extrapulmonary tuberculosis sample for CBNet or TrueNet. Yes, that's a big issue. For example, cerebrospinal fluid has very good sensitivity for extrapulmonary tuberculosis sample for the TrueNet test. But fluid like pleural fluid, the urine sample and other sample, they are having less sensitivity. So I think what we are practicing in India, that we are not doing one sample, we are doing 2 samples. So by increasing one sample means this sensitivity of the TrueNet or CBNet get increased, number 1. Number 2 is that from where you are taking the tissue sample, from where you are taking the sample, that's also important. So sample from the right place and in right quantity. At least 2 ml of the pus or 2 ml of the sample should be taken for processing of CBNet or TrueNet. So I think if we take the sample from the right place, it is in right quantity and timely process to the lab. These are some important factors for increasing the sensitivity. And we should not only do the one test. Sensitivity of the TrueNet and CBNet.
Thank you.
Excuse me, Chairman. Because I had joined late because of my clinical engagement this morning. So I had not followed through the whole lecture of Professor. So of course, I would be grateful if you could have the, as usual, to have the recording for us with PowerPoint. And secondly, in fact, it's a personal question for Professor Kant. My mother had died 6 years ago, and at the age of 102. And in fact, when she was in her last 2 months of her life, she was somehow suspected and then diagnosed to be suffering from tuberculosis. All right, and she's ill already. And she had a history of stroke, and then etc. So the physician had given her rifampicin and also an isoniazid, and then her liver function had suffered a little bit. So in fact, she's already bedbound. So how would we approach such patients? I mean, terminal. And then
Sir, fantastic question. I would say the question of the day. It is a very good question. You see, addressing or treating the tuberculosis in elderly is an entirely different topic, because liver functions in the elderly, they are usually compromised. So we have to closely watch on liver function whenever we are giving the anti-tubercular treatment. It's an entirely different issue. So I think repeated liver function testing and monitoring should be done whenever we are treating with the elderly TB. And if the patient is not able to tolerate the all four drugs, that is rifampicin, isoniazid, ethambutol, and pyrazinamide, because rifampicin and pyrazinamide are the two most important culprit for the altering liver functions. So I think if such situation happens, then we have to give some additional the hepatoprotective drugs. And in addition to this, we can modify the treatment. We can give only the liver safe anti-tubercular drugs. So especially if we, of course, presume or assume that yes, patient's liver functions may be compromised, so we can give the liver safe anti-tubercular drugs. For example, isoniazid, ethambutol, or even we can modify ethambutol and levofloxacin. So these type of drugs can be given in place of traditional rifampicin, INH, ethambutol, pyrazinamide, the four drugs. Yes, up to you.
Thank you very much.
Okay. Anything else, Alvin?
Well, of course, I would like to ask about the situation in pediatrics in India or in Professor Kant's experience, if you could enlighten me on that. Of course, as I had said, I seldom encountered tuberculosis in our pediatric cases in private practice.
Dr. Chen, wonderful question. The pediatric TB situation in India is that we have 26% of overall global share of the TB in India. And roughly 26 lakhs means 2.6 million cases of TB in India every year. And out of this 2.6 million, 0.1 million cases of pediatric TB are there. So important share of pediatric TB is there. And the single most region in this country is the malnutrition in children, which is posing a kind of additional risk factor for developing tuberculosis. So that's why I said in the beginning of the lecture, you will get the recording of the lecture and you will see in the beginning of the lecture cited that unless we address the issue of malnutrition, we cannot eliminate the TB from the world or in any country.
Thank you.
Thank you, Dr. Surya Kant. And I think our time is running out. So without much further ado, if there are no more questions from the floor, I thank everyone for this attendance and Dr. Surya Kant for a wonderful discussion on our old enemy, TB, who has been around since the time of the Egyptian mummies. So thank you very much.
Thank you.
Thank you.
Thank you.
Thank you all. Thank you.
Thank you.
Bye-bye.
Bye.